Welcome everyone. Thanks for joining us for today's webinar on VASCEPA, icosapent ethyl, elevating the standard of care. If you would like to ask a question during the presentation, please type it into the Q&A box on your screen at any time, and we'll answer as many questions as possible during the Q&A session at the end. Our presenter today is Dr. Robert Bush. Dr. Bush is Director of Clinical Research at Albany Medical College in Albany, New York. He's a board certified in internal medicine and endocrinology and metabolism. His principal research interests include studies in type 2 diabetes, osteoporosis, cardiovascular safety, renal protection, and resistant hypertension. Dr. Bush has authored or co-authored articles published in peer-reviewed journals such as Clinical Medicine Insights, Endocrinology and Diabetes, Endocrine Practice, Diabetes Technology and Therapeutics, and the American Journal of Health System Pharmacy. And joining us for the Q&A session later is Dr. Curtis Triplett, a pharmacist and certified diabetes care and education specialist. Financial support for this program is provided by Amarin Pharma. The speaker is a paid consultant for Amarin Pharma, and there is no continuing education credit for this webinar. So without further ado, I will turn it over to Dr. Bush to begin.
Well, thank you very much. It's a treat to be able to present to so many diabetes educators and to present with Dr. Triplett. What some of you may not know is Dr. Triplett is the PharmD working with Dr. DeFranzo, and everyone knows Dr. DeFranzo and Dr. Triplett. Anyway, what I'm going to be talking about is the VASCEPA and the REDUCE IT trial. So let's start off with the new indication for VASCEPA. Well, first, the old indication was for triglycerides over 500 with patients with hypertriglyceridemia. But the exciting new indication, which is very unique for VASCEPA, unlike any of the other triglyceride-lowering drugs that don't have this indication, is an add-on to maximally tolerated statin, which means anything from 0 statin, if that's the maximum you could tolerate, to the top dose of statin, to reduce myocardial infarction, stroke, revascularization, and unstable angina that requires hospitalization in patients whose triglycerides are 150 and higher, who either have heart disease underlying, ASCVD, which could be an MI or a stroke or an angioplasty or a TIA or peripheral vascular disease, or diabetes and 2 risk factors. And this is where all of us come in. Yes, we all see patients with heart disease, with or without diabetes, but certainly as educators, you're all seeing patients with diabetes with 2 or more risk factors. And we'll go through some of those risk factors later. So those are the 2 indications, but the new and exciting one is to avoid, and many of you know the term MACE, multiple adverse cardiac events. MI, stroke, revascularization, unstable angina, and you identify these patients very easily. They're on maximal tolerated statin, their triglycerides are high, and they have diabetes and risk factors or established heart disease. Now, the limitation of use is it's not clear if VASCEPA lowers the risk of pancreatitis. Many of us have drugs to treat patients with triglycerides 500 or more to hopefully avoid pancreatitis, but it's not clear if this is what it does for that second indication. Now, safety information, we'll review this. Don't give it if you're allergic to this or any other drug. You don't give any drug if you're allergic to it. Now, there is a slightly higher risk of atrial fib, 3% versus 2%, for requiring hospitalization for atrial fib. But the incidence of atrial fib was higher in patients who have a previous risk of atrial fib, who had previous atrial fib. Now, for patients allergic to fish or shellfish, they may be at a slightly higher risk of an allergic reaction. It's not contraindicated, but if you were going to do that and they had an allergy, stop therapy. There is a higher bleeding risk, 12% versus 10% in the double-blind placebo-controlled trial, but there was more likely to have a bleeding risk if you were on other drugs that were antithrombotics, such as aspirin, clopidogrel, or warfarin. In the big cardiovascular trial that we'll be reviewing, they're looking at things that had a higher incidence of 3% versus 1% for placebo, was musculoskeletal pain, peripheral edema, constipation, gout, or atrial fib, as we mentioned earlier on. So in terms of adverse reactions, the most common adverse reaction in some of the other studies was arthralgia, 2% versus 1%. And for adverse reactions, you know where you could be calling. and when it's taken with concomitant anticoagulants, one should consider monitoring for bleeding. Oftentimes, someone might stop the VASCEPA a week before surgery. So VASCEPA is a prodrug, and it is converted to EPA. EPA is one specific type of omega-3, and it is unique in that this is you're giving 2 grams twice a day of EPA, and it's pure EPA. So that's what VASCEPA is, why the name has EPA at the end. So let's go through what we're going to be discussing. We're going to go over the urgency to lower persistent cardiovascular risk on patients on high doses of statins. So even though someone is on a statin, they still have a risk for cardiovascular disease, and we'll go through some studies that show that. We'll go through that the VASCEPA is the first and only FDA-approved medication on patients on maximally tolerated statin to lower MI, stroke, revascularization, or unstable angina in patients whose triglycerides are over 150 with either previous established ASCVD or diabetes and risk factors where they didn't have to have ASCVD, just diabetes, and it could be type 1 or type 2 diabetes with additional risk factors, which could be hypertension, high urine microl, GFR below 60, smoking, a family history of heart disease, low HDL. So, it's almost hard to find someone with diabetes who doesn't have additional risk factors. The REDUCE-IT results that we'll go over shows unprecedented cardiovascular risk reduction, and will show that it lowered MI, stroke, unstable angina, hospitalization, as well as revascularization. And because of the impressive data, many of the leading medical bodies, including American Diabetes Association and Heart Association, American College of Endocrine, and a lot of the European societies recommend this to be given based on what we just went through with the label. Now, you know that heart disease is the biggest killer in the United States and much higher than cancer and lower respiratory disease. And if we look at the incidence of heart disease, it dramatically went down over the last 10, 15 years and then started going back up again. So what caused the downward slope? Well, we know those big studies, the HOPE trial with ACE inhibition, and we know about the statin studies with 4S and CARDS and all the statin studies, so why we use RAS blockers and statins in the drinking water of patients with heart disease or diabetes. But despite those great drugs, there's an uptick. Smoking is still there. Diabetes is very common. There's a lot of hype about not taking statin because of setting off diabetes or getting muscle aches from it or some other perceived potential risks of statin therapy. So there is still a very high rate of heart disease despite terrific drugs that we have. The cost of heart disease far outweighs many of the other medical issues that we deal with. And let's look at some of that persistent risk or residual risk that some of you might refer to. These are 3 very big studies that were recently done on patients on high-dose statin therapy and the rate of getting cardiac events despite being on standard of care. The first study is the study with the drug Repatha called the Fourier trial. And in that study, the patients were all on statins. Their LDL to start with was 90, and they were well-managed cardiac patients, and despite that, they still had almost a 15% rate of heart disease over the next 3 years. The REDUCE-IT trial, which I'll be reviewing, this is the placebo group who were all on statin therapy with an average LDL of 75 to start with. Despite the LDL of 75, again, you could see 28% risk of having a cardiovascular event. And the blue line is the study called IMPROVE-IT. Many of you are familiar with this with ezetimibe, that when you added ezetimibe to a statin versus statin alone, in the placebo group before the ezetimibe, the LDL was 70, and look at the rate of heart disease despite an LDL of 70 on statin therapy. So these are patients with well-controlled LDLs, and despite that, with an LDL going from 69 to 94, they still had very high risk of heart disease or high persistent cardiovascular risk, despite being on RAS blockers and high efficacy statin. Now, what about the importance of triglycerides? Well, we know if triglycerides are way high, 500 or more, they might be at risk for pancreatitis. But if you look at the Framingham Offspring study, and this is cardiovascular risk, as you go from a triglyceride of 100 to 200, that's the biggest upslope, that high triglycerides that are not sky high, 100 to 200, which you see every day, increases the risk of heart disease dramatically. And on the right is the Miracle trial. This was a study in patients who just got out of the hospital after an MI or a stroke, hospitalized for unstable angina. And these patients, if you looked at and they were all put on high-dose atorvastatin. Well, those who had high triglycerides, 195 or higher, versus those who had triglycerides under 135, if you look at week 16, they were 25 to 50% higher risk of heart disease, of having another cardiac event, just because their triglycerides were high. And the triglycerides weren't that high, 195 or 130 to 195. So this is showing that triglycerides give sort of an indicator of there's additional persistent cardiovascular risk. Now the question is, will giving VASCEPA to this type of patient who has this extra risk, despite being on a statin, make a difference? And that's what we're reviewing with the REDUCE-IT trial. Now, how often do you see these patients? Every day. I personally recruited patients for this trial in association with my diabetes educators, because educators are seeing the patients. You have the labs in front of you oftentimes, and you could identify these patients very easily. There are felt to be 17 million adults in the U.S. with a triglyceride over 150 who either have established heart disease in purple or who have diabetes and risk factors. So these patients are very easy to identify, and as the team that is there to identify the patient, sometimes you're the final stop. If the clinician didn't identify it, you could alert your clinician that you work with that, wait a second, this is a patient at higher cardiovascular risk. They're already on a statin. They've had heart disease or diabetes and risk factors. What can we do about it to lower their cardiovascular risk? And that's what we'll be reviewing the rest of the talk. So here are 3 such patients. The first patient had a previous heart disease. He's 57, had CAD in the past. He's on a statin, his LDL 68. He's on atorvastatin 80. You say, okay, great. But his triglycerides are 185. This should not be ignored with a triglyceride at this level. He's one who qualifies to be in the REDUCE-IT trial based on the criteria, because he has heart disease with a previous event, on statin, LDL certainly reasonable, but his triglycerides are persistently high, indicating persistent cardiovascular risk. The next 2 patients have had diabetes. Donna was 42. Her A1C is 7.9, so maybe she could use some better control there. Her LDL is 84. She's on a statin. You know that statins are in the drinking water of patients with diabetes based on many of the previous studies. But her triglyceride is 150, indicating persistent risk. And finally, James has diabetes and peripheral artery disease. He's a smoker. He's on a statin. His triglycerides are 320. So none of these patients had triglycerides over 500, the old traditional treatment using any kind of omega-3. But here we're specifically targeting these patients who were at higher cardiac risk. They're already on a statin, but this patient had heart disease to start with, this one diabetes and risk factors, and this patient diabetes and previous PAD. They have high-ish triglycerides despite an LDL that's reasonable on statin therapy. So now we'll talk about what can VASCEPA accomplish in these patients, and here is the REDUCE-IT trial. The REDUCE-IT trial took patients with either established CVD, that was 70% of the patients, or 30% of the patients had type 1 or type 2 diabetes with risk factors. And look at the risk factors here. They're before you every day. Age over 45 in men, 55 in women. That could be a risk factor. Hypertension, hypercholesterolemia, well, they're all going to be on a statin. Low HDL, smoking, GFR, CRP isn't always done in patients. BMI over 25, certainly you're surrounded by that every day. If the GFR is below 60 is a risk factor. So it's almost hard to find a patient with diabetes, especially type 2, who doesn't have 2 risk factors. These patients are in front of you every day. They're on maximally tolerated statin, so it's not an LDL cutoff. It's that they're on top dose statin that they can tolerate. Some people can't tolerate any. Some can tolerate rosuvastatin once a week, and some can tolerate top dose rosuvastatin or atorvastatin. And importantly, what identifies the patient when you're looking at their record, their triglycerides are over 150. These are very easy patients to identify, patients with heart disease or diabetes and risk factors. And of course, some of these heart patients also had diabetes as well in the study. So we're going to show you unprecedented risk reduction by the use of VASCEPA added on to these patients. This was the #1 cardiovascular story of 2018 and 2019. It was presented at the heart meetings by Dr. Bott in November of 18 and reviewed by the FDA and put in the package insert after they reviewed the data at the end of last year, and it was the lead article in New England Journal this year. So who are these patients? 8,000 patients, well-controlled LDL with an LDL of 75 on statin therapy. Their triglycerides were 135 to 499 to start with. So those were the triglycerides, which in the past you would overlook that. Now you look at a triglyceride like this in a patient on a statin, and it's your obligation to do something, as you see when we go through the data. 70% were over 45 with established cardiovascular disease. Some of those patients had diabetes, and all of these patients had diabetes with an additional risk factor. So that's the group, primary prevention and secondary prevention. They were all on statin therapy already, and you either added 2 grams twice a day of VASCEPA or adding placebo. But these were not placebo-managed patients. These were patients on standard of care. Many were on dual platelet inhibition. They were all on a statin. Many were on RAS blockers. The cardiac patients were on beta blockers. So these were well-managed cardiovascular patients or patients with diabetes. And what they looked at is the first occurrence of MACE. MACE, to review, is multiple adverse cardiac events. What is MACE here? 5-point MACE of 5 different issues: non-fatal MI, non-fatal stroke, cardiovascular death, revascularization, or unstable angina requiring hospitalization. That's called 5-point MACE. That was the primary endpoint. The secondary endpoint was 3-point MACE. Some of you may know that's called hard MACE: non-fatal MI, non-fatal stroke, or death, because that's very objective. You either died or didn't die, or had a stroke or didn't have a stroke. Whereas 5-point MACE, it's more subjective with hospitalization or revascularization, but hard MACE or 3-point MACE is often the outcome in many of the studies you're aware of, like the GLP and SGLT2 cardiac studies that you're very aware of. Now let's look at these patients. Their average age was in the 60s. About almost 30% were women, which is pretty high for a cardiovascular trial. As we said, by design, 70% had known heart disease and 30% had diabetes and risk factors, but the percentage of diabetes overall was almost 58%. So some of the heart patients also had diabetes. There's a fairly robust amount of patients with diabetes in this study. That's why, as educators, you're going to be seeing these patients every day. You see patients with diabetes with or without heart disease, but with risk factors who are on a statin. Their LDL is reasonable. They're on maximal tolerated statin, but the triglycerides are still high. 10% had triglycerides 135 to 150, and you could see about 30% 150 to 200, and then 60% over 200 up to 499. Their LDL levels, the average LDL was 75 to start with. Most of them were on moderate or high efficacy statin therapy, and they were on antihypertensives, they were on antiplatelet, they were on anti-diabetic drugs if they had diabetes. Parenthetically, their average A1C to start with, believe it or not, was 7 in this trial. So let's see what happened. So here's the placebo group. I showed you that before. Now remember, they're not on placebo. They're on placebo for VASCEPA, but they're on statin therapy. Their LDL 75. Many of them are on dual platelet inhibition. They're on RAS blockade. So they're well-managed cardiac or diabetic patients, and they still had a 28% risk over the next 5 years. Giving the drug, it went down 25%. Now, the absolute risk reduction, if you looked at about year 5, is 4.8%. And for those not familiar with it, if you divide the number 100 by the absolute risk reduction, the number needed to treat is 21 patients treated for 5 years lowered their event rate of one of those 5 events: non-fatal MI, non-fatal stroke, cardiovascular death, revascularization, or hospitalization for unstable angina. That's the primary endpoint. This is what was so exciting. And look how many zeros in the p-value, 7 zeros before that. Now what about hard MACE, MI, stroke, death? something you're more used to from some of the diabetes outcome trials. Here's hard MACE, went down 26%, lowering MI stroke death also with a lot of zeros before. And again, number needed to treat 28. So those were the two primary endpoints. A primary I showed you, 25%, MI stroke death, 26%. Did it make a difference of the triglyceride level? No. It didn't matter if your triglycerides ended up above 150 or below 150. Either way, you had benefit. This is not a lower is better study like with a statin. Triglycerides are the marker of persistent risk, and giving VASCEPA as a cardiovascular beneficial drug, didn't matter what your triglycerides went to, it lowered event rate dramatically. So in the study, VASCEPA was associated with a slightly higher risk of atrial fib, particularly in those patients who had atrial fib in the past. So there was a slightly higher rate of atrial fib hospitalization. We talked about the higher bleeding rate, particularly if they were on anticoagulants. Remember, some of these were stent patients on dual platelet inhibition or atrial fib patients on warfarin or other blood thinners. And the highest, the incidence of other events we talked about in the package insert before, constipation, peripheral edema, or atrial fib. Now, in terms of adverse events, you can see the p-values here is not much different with placebo versus VASCEPA. So in terms of serious adverse events or withdrawal from the drug, there was not much different than placebo when we looked at that. Now, they looked at the U.S. population. This is an international study. And many of you are aware, some studies in the U.S. don't make it, but globally do, and they get the label, like in the LEADER trial that happened. So here, it was interesting to see what did the U.S. population do, and 3,100 of these 8,000 patients were from the U.S. This is of interest for qualitative, not quantitative. So this is just out of our interest, how did the U.S. patients do VASCEPA versus no VASCEPA, because that's who we treat, U.S. patients. So in terms of the first cardiovascular event, remember before it was 25%, now 31%, very consistent with the other data. MI stroke death, hard MACE, 31%, non-fatal MI, 28%, non-fatal stroke, 37%, death, 34%, and all-cause mortality. These were all statistically significant. So this is qualitatively very interesting when you're treating a patient and discussing, why do I want to prescribe VASCEPA? You have a U.S. patient who qualifies, their triglycerides are over 150 with risk factors or heart disease in the past, and this is the data that you're sharing with the patient in layman's terms to lower MI stroke, revascularization, et cetera. So the future of care starts now. You have these patients in front of you every day. And if it was a missed opportunity by the clinician who saw the patient, I tell when my patient sees an educator, I say, I'm coach and my educator is first class. So they upgrade to your care. Don't miss that the patient has persistent cardiovascular risk with a high triglyceride level, and then do something about it, because VASCEPA works, whereas other drugs don't, as we'll be going over. So all of these organizations endorse this fully, that patients with diabetes and risk factors, or people with heart disease in the past, who are on a statin with an LDL controlled with triglyceride over 135, they recommend giving 2 grams twice a day of VASCEPA. You can see all the U.S. organizations with ACE and Heart Association and American Diabetes Association, the European associations as well, strongly endorse this. This is not endorsing fibric acid or niacin. These studies were negative studies adding fibric acid. Even though fibric acid is used very commonly and it may lower triglycerides, it does not have cardiovascular benefit. There is no benefit, no guideline support, and the FDA revoked the package insert saying add a fibric acid. So even though that's often done, it doesn't work. Whereas EPA from the REDUCER trial, VASCEPA, which is pure EPA, not only has proven cardiovascular benefit that we reviewed with you, but it lowers risk reduction and strongly recommended by a lot of the guidelines. VASCEPA is not your grandmother's fish oil. So VASCEPA is FDA approved. It's a single agent. It's all EPA. It does not increase LDL, and it's a very carefully regulated FDA manufacturing process. Whereas Epanova, or the other omega-3 you're familiar with, Loveza, does not have these indications. Even though it's an FDA-approved omega-3, and it's approved to lower triglycerides of over 500, it does not have cardiovascular benefit. In fact, it's shown cardiovascular safety, but not benefit. And dietary supplements, we don't call this over-the-counter. It's not FDA recommended. These dietary supplements are, aisle 3 at the bottom, as the pharmacist might direct you to, inappropriately, because they have no additional benefit. They're not FDA regulated, and many times you don't know what you're getting. You can be getting saturated fat in the omega-3, and some of the popular ones that are often advertised. So these omega-3s are very different than the prescription ones, and the prescription omega-3s are very different than VASCEPA or EPA. So if we look at other cardiovascular trials that we all live by when we treat our patients, in the treat to new targets, 10 versus 80 of atorvastatin, number needed to treat 45 to lower MACE 22%. In the improver trial, 6% lowering by getting LDL to the 50s from 69 by adding Zetia. In the Repatha trial that I showed you earlier, a 15% lowering of MACE, number needed to treat 67. In the VASCEPA trial, we showed you in the Reducer trial, 25% lowering of that 5-point MACE, number needed to treat 21. And in the U.S. population, 31% lowering, or number needed to treat 15. So very impressive data in patients already on a statin with a good LDL, but persistent risk as shown by the high triglycerides. So previous studies as well as this show the safety of the drug, the dosing, which is 2 grams twice a day, and it's very cost beneficial. In fact, for commercially insured patients, when the drug is approved, it's a $9 copay for 3 months. It's less expensive than some of the other products that have no cardiovascular benefit. So, as we reviewed, VASCEPA in the Reducer trial is breakthrough therapy. Remember, when we walk in the exam room with someone with diabetes, where's your statin, where's your RAS blocker? And as we all know, when we treat diabetics who've had heart disease in the past, type 2s, where's your GLP or SGLT2 that has cardiovascular benefit, according to ADA and ACE guidelines? Now we're talking about VASCEPA if the triglycerides are over 150 and they have 2 additional risk factors, or they have cardiovascular disease with or without diabetes, that you lowered 5-point MACE 25%. You lowered 3-point MACE, MI stroke death 26%. Each individual component made it. You look at the p-values here. So non-fatal stroke went down 31%. Non-fatal stroke 28%, non-fatal MI 31%, and death 20%. So this is the data I discussed with the patient. Patients roll their eyes when you want to start another medicine, particularly giving 2 capsules twice a day and another copay for them, although it's an inexpensive copay with the commercially insured patient with the card. But in any event, this is how we sell the science to the patient. You always want to do one better than you did before. Many of us have been practicing long enough that I started in an era with no statin and 1 RAS blocker. And now we have an abundance of medications that we could treat the patient with, not only to lower their A1C, but to lower cardiac risk with aggressive statin therapy, or Zetia and statin, or PCSK9 and statin. We can get LDL down easily. We can get blood pressure down with a variety of drugs we have, and we have heart-smart diabetes drugs. This should be part of your armamentarium, and you may be the one to identify the patient if the clinician missed it. If the triglycerides are 150 to 499 and they have diabetes type 1 or type 2 with risk factors, or have a previous ASCVD event, they should be on VASCEPA to get this kind of data. Talking to a patient, say, I could lower your risk of stroke 28% on top of your statin, or risk of cardiovascular death 20%, or the composite 25%, this resonates with patients with a drug that has the risk-benefit ratio, the very little risk and major benefit across the board with all these parameters. So, to summarize, in a patient with established ASCVD, and it doesn't have to be heart, it could be a stroke or TIA, carotid disease, it could be peripheral vascular disease, who has had that in the past, or who has type 1 or type 2 diabetes with risk factors, they're on maximally tolerated statin. If their triglycerides are over 150, indicating to you that they have persistent cardiovascular risk, it's your obligation to start VASCEPA to have that type of benefit in the patient. So thank you very much, and I look forward to having the Q&A period with Dr. Triplett.
All right, thank you. That was a lot of great information and fantastic data in the field of cardiovascular risk reduction. So thank you, Dr. Bush. So at this point, we will move on to the question and answer portion of the webinar. And joining Dr. Bush to help answer your questions today is Dr. Curtis Triplett. He is a pharmacist, certified diabetes care and education specialist, and associate professor of medicine at the University of Texas Health Science Center at San Antonio. Dr. Triplett has published over 50 peer-reviewed articles and 10 diabetes management book chapters, and he has served as past president of the ADA's South Texas chapter, vice chair of the Texas Diabetes Council, and is the current editor-in-chief of the journal Diabetes Spectrum. So let's jump right in. So Dr. Bush, what impact has the Reduce It trial had on your practice?
Well, so when we all go to work, you want to do one better than you did the last time. It's not just there to renew prescriptions and everything's good. When the GLPs and SGLT2s have their cardiovascular benefit as heart smart drugs, it was very exciting to wash through the practice and upgrade the patient's diabetes care. And when other drugs that could lower LDL better than what we had with just statins came out, that was exciting. But these patients have persistent risk, and if the triglycerides are 150 or higher and they have risk factors, that's a patient that it's your obligation to treat the patient with VASCEPA. And remember, you're treating, how do you know it's working? Well, they come back the next visit. They haven't had a heart attack, stroke, or died since the last visit. So, you're not doing it to say, oh, I got your triglycerides way down. The triglycerides are the marker of persistent risk, and giving the drug has its pleiotropic benefits, whatever the EPA is doing, and there are many theories of what it does. So the impact to my practice is it's lowering the persistent cardiovascular risk despite doing the best I can with the other drugs. So Curtis, what do you
Dr.
think?
Triplett.
Go ahead, sorry.
Oh, yeah. So one of the things that, I think our practices have been highly influenced by actually all the rest of the omega-3 trials. And so one of the things that happened, I think, in our practice, even after the New England Journal article was published, is we were almost in disbelief. And I think it's because we wanted to know why and how, and why is everything else so negative, and why is this trial so positive? And a lot of those answers have come out. And so one of the things that we're starting to do is we're starting to use this drug more often. And I think that's one of the things that really we've noticed is that this is a, there's lots of other products and there's lots of other studies, and they were all negative, including the one that just came out with a different product, the Ethanova. So, we were so jaded, the fact that this was like a one-off trial, that I think we waited. And now that we were done with the wait period, I think we fully understand how, why, and we've kind of moved forward into starting to use it a lot more. But I think it was definitely lagged based on prior data and trying to figure out why this was so different, which now we have some of that information.
Wonderful. Thank you both. The next question is a two-part question, and Curtis, I'm going to throw it to you. It says, what percentage of your patients are good candidates for VASCEPA, and how do you identify those appropriate patients?
Well, I got asked this question a few days ago, and one of the things that we've been doing mostly, and I fully admit this, is we've been kind of the diabetes data just came out, but one of the things that we were doing is kind of hedging towards people with established cardiovascular disease. So one of the things that we have, of course, I see diabetes patients, and so the bar for treating diabetes patients, and there was about just under 60% of those patients in the study had diabetes. And I think one of the things that happened was the ADA data that just came out, and Dr. Bush can speak to it more, was incredible. And so I think what we're doing is we're really seeing a surge of interest, and we tend to Now that we know how to use it, we're seeing it, and the data is showing with or without cardiovascular disease, I think we need to re-look at our criteria. But all of my patients have diabetes, and almost all of my patients have 2 risk factors. So all my patients that are on a maximally tolerated statin, which is basically all of my patients, because we try to maximize the statin, I think it's logical that we need to start looking at this next.
Dr. Bush, what are your thoughts on that?
Right. I highlight what Curtis said, and he mentioned how the patients with diabetes did. So this hasn't been published yet, but it was announced at ADA. The patients with diabetes overall did even better than the overall pop. If you had diabetes and heart disease, they have an extremely high persistent cardiovascular risk, as indicated by high triglycerides, and it dramatically comes down with the EPA. We don't know why the EPA does this. It's not just triglyceride lowering. There's other pleiotropic benefits, just like statins have other pleiotropic benefits. But as we know with statins, as Curtis said, lower is better. Here, the high triglycerides create the obligation that the patient has additional cardiovascular risk, but that's the obligation to start the VASCEPA. So it's not that you're lowering the triglycerides and following it afterwards. Yeah, patients want to latch on to that. You have to explain to them. It's not like when I get your LDL down. High triglycerides show me that you have additional persistent or risk, but then giving the drug lowers that risk dramatically. And if they have diabetes or diabetes and heart disease, it even more dramatically lowers the risk. And these patients are in front of us every day and missed. I can tell you more often than not, when I'm seeing someone with diabetes and heart disease, you think the cardiologist would have started this because it's recommended by the Heart Association. I'm usually the one starting it. And as the educators, you're the one who could really impact the patient's life by doing this. You saw the data across the board for each endpoint, for MI, for stroke, for cardiovascular death, for the composite. And if that was missed by their clinician, you could really help them in a major way and in an affordable way as well, if it's covered by their plan, especially if they have commercial insurance.
Great. Thank you. Dr. Bush, what role do fibrates, niacin, or mixed prescription omega-3s play in your treatment of cardiovascular risk?
Well, the role they have is I would call it deprescribing that. I'm quoting Dr. Bott, who is the lead author, that those are very overprescribed. The omega-3 food supplements are overprescribed because they sound natural, but you may be having saturated fat. Fibric acid was something we've used for many, many years, but the outcome data isn't there in the overall population. In the ACCORD trial and the FIELD trial did not show benefit using fibric acid. So these are overprescribed and blocking the prescription for this. So when I'm starting this, I'm getting rid of those drugs with the patient, saving them money that they're wasting their money on drugs that don't have cardiovascular benefit and giving them a drug that has proven benefit. So this is the only drug that has that benefit beyond, the LDL lowering therapy. So statins have benefit, ezetimibe has benefit, PCSK9s do, but this is the only triglyceride lowering drug that has benefit. Niacin, omega-3, and fibric acid does not have cardiovascular benefit from their current trials.
Great. Curtis, do you have anything to add?
Dr. Bush is absolutely right on it. I mean, I don't think we have any patients on niacin anymore. That definitely has gone out the window. Fibric acids are very limited. As he was saying, there's lots of data. ACCORD and FIELD trials, all negative. And they clearly say that this combination doesn't make sense. There could be a subset of patients that you, as a clinician, knowing the trials, could use it on. But I think what you're finding with this drug is that it didn't matter the subset. If you look at the trial, you're going to find that it benefited all patients. So if you're trying to use something in a trial that's a subset and find out, I'm going to use it for this patient, I think right now all we're using fibric acids for is extremely high triglycerides. And as I said before, niacin is no patient. And, oh, I'm sorry.
Beautiful, thank you.
Yeah, and I forgot the over-the-counter. One of the things about the over-the-counter ones is we weren't actively managing that in our patients, I don't think. But what we've been doing over the last few months is trying to actively manage that more. And if they're willing to take that, it's an easy transition as long as they can get it. It's an easy transition because the drug is considered natural, and patients tend to like that kind of term. So we haven't had a problem with the transition if they can get it.
Great, thanks so much. Curtis, the next question is for you, and it says, what role can the certified diabetes care and education specialist in your practice, and for those listening to today's webinar, what role can they play in managing persistent cardiovascular risk for people with diabetes?
Well, I think diabetes educators play an extremely important role in this. And when you talk to diabetes educators, I mean, they have so many things that they cover with our diabetes patients. I mean, we're talking about blood pressure, how to lower it, weight management with blood pressure, salt, diet, Mediterranean diet things, weight, cigarette use, sugar control, physical activity, and then, of course, in the diet, trying to talk about saturated fats and trans fats and things like that. So there's so many things I think that dietitians and diabetes educators are already doing, but I think that lifestyle is still the cornerstone, and we're adding these other therapies upon that. So we shouldn't take those for granted. We should continue to do that. Of course, we know it looks like in these patients now we need to add at least a statin and maybe some omega-3s. So I think this is very important data for us to consider.
Great, thank you. Dr. Bush, do you have anything to add from your perspective on that?
Well, as I said earlier, and I truly mean this, when I walk in, my educator, I'm very spoiled, so the one I use the most is right next to me, and we share lots and lots of patients. So when I go in the room with her, say, okay, maybe I was coach and I got all the other things, but now you're upgrading to first class. But very importantly, the educator's the safety net as well. You have all the data in front of you, hopefully, from the patient's visit, and the enforcement not only of lifestyle and diet, but where's your ACE or ARB? Where's your statin? Is the statin titrated enough? If the LDL is not at goal, you know the same goals that we all know. And the triglycerides are often missed. They're not looked at unless they're over 500. You could play a very major role for cardiovascular risk protection. Sometimes the clinician gets so caught up in the diabetes management, they didn't start the statin, or this patient with proteinuria and there's no RAS blockade. So those are the kind of things that through appropriate suggestions, it's hard to call your clinician and say, by the way, you missed blah, 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 but maybe pointing that out. Maybe they're not as familiar with the reducer trial that you are now, or the importance of aggressive LDL lowering, or some of the other things that you do, or even where's the GLP-1 or SGLT2 if they have cardiac disease. That you certainly, if you had a patient with heart disease and they're on a DPP-4, metformin, and a sulf, and there's no GLP or SGLT2, you play a very major role as sort of the bottom line and security blanket to the clinician so that you could upgrade their care.
Wonderful, thank you. For the next question, I would love to get both of your perspectives, but Dr. Bush, I'm going to ask you first, and it's, what are the most common questions that patients ask you about VASCEPA?
The most common question would be, why can't when I went to the pharmacy, they recommended that I get, blah, blah, blah fish oil that they saw on TV, that maybe, or get the omega-3 that, I forgot the news commentator who's in his age, Larry, whatever his name is, he advertises that on TV. So, these kind of products are not regulated. They're food supplements. They're not considered over-the-counter. They're actually, on the bottom shelf somewhere, and there's a whole section of them, and they seem like natural products. Well, first of all, the other omega-3s that are prescription drugs, for example, Lovesa, raises LDL cholesterol. VASCEPA doesn't raise LDL. That might be one of the differences, and there are many other. VASCEPA is the only pure EPA, and there's some other pleiotropic benefits, speculated by the EPA. And in fact, Dr. Bott did an analysis based on EPA levels, which you can't reach with those other omega-3s, and it may be the higher the EPA level, the more benefit. There was another EPA study done in Japan called JELIS that some people might be familiar with. That also showed cardiac benefit. So now we have data from the Japanese study and this study that EPA is cardiac beneficial, and none of the others. There's plenty of data, but it's not beneficial.
Great. And Curtis, what are some common questions that you hear about VASCEPA?
Yeah, I think that's, Dr. Bush actually covered a ton of the space that needs to be covered for this question. You know, most of it is exactly what he said, is why do I want to pay this much for VASCEPA when I can actually go get an over-the-counter, or I can go get this other supplement, and, you know, it has to be all the same. And it is really a discussion of why it's different, and, you know, you have to kind of tell them in a layman term, nothing else has worked in this space. And this is the only one that has a reason to work based on what Dr. Bush just said about EPA levels. And so everything, I think, has kind of become crystal clear, you know. And the other thing I mentioned to them is, you know, gosh, you know, such a benefit now. It's an easier conversation now. I mean, you know, 1 in 10 people benefiting from the drug over 5 years in diabetes, things like that. And then, of course, they ask about side effects, and we talk about GI and, you know, nuisance bleeding and stuff like that. But overall, most patients tolerate it pretty well.
Great, thank you. And actually, our next question kind of relates to what you both said there. So, Curtis, I'll have you elaborate here, and it's a two-part question. It says, how is VASCEPA different from available dietary fish oil food supplements? And how do you counsel patients currently taking dietary food supplements for cardiovascular benefits?
Yeah, we kind of covered this in a roundabout way already. I mean, obviously VASCEPA is a very pure EPA, and you know, that was one of the things that we had really serious questions about, is why is this different? And it's clear now through the data that Dr. Bott did that it's EPA levels. EPA levels are important, and that has changed our thoughts. And now that we understand that the other ones, which are 20%, maybe a half a gram per gram pill, that you would have to take a very large dose to get the kind of results that you see from VASCEPA. And by the way, every time they tried to do a 4-gram dose or something like in the strength trial with the Ipanova, as we just said, it just didn't work. In fact, they stopped the trial because it just didn't work. So the answer is you have to think about this as different. And that's the hardest thing a lot of times for people to get over, because they want to save money. You know, they don't want to spend more than, oh, I just want to take this one little omega pill every day, and I want it to, you know, help me because I think it's going to do something. And the answer is, it's clear that it does not. And so we have to re-educate on the fact that there's only one that actually helps, and it's very clear why now.
Great, thanks. And Dr. Bush, do you have anything to add on to that?
No, I think that summarizes it. And it's hard to break that habit. Many people think that, you know, that these food supplements are natural substances. And as Curtis pointed out, AstraZeneca did the same study with 4 grams of their mixed EPA DHA, and the study stopped for futility. It didn't work. And the JELIS trial that used a lower amount of EPA, this was in Japanese patients who eat a lot of fish. So when they came up with the 2-gram twice-a-day dose in the U.S. study with VASCEPA, they looked at the EPA levels in that Japanese population where the drug had benefit, not the same EPA that we have VASCEPA, but a different EPA that had benefit there, and they try to simulate it by giving a 4-gram dose here, because remember, Japanese are very high in fish in their diet, which we are not. So they specifically used a dose like this to get EPA levels respectable, and that probably is the best correlation that you can't get with the other omega-3s, either the supplements or the branded, the ones that are prescription drugs.
Great, thank you. Dr. Bush, can you provide your clinical perspective with respect to what is the best way to lower triglyceride levels and raise HDL for people who do not have diabetes?
So if triglycerides are 500 or more, it's felt that you should get the triglycerides down to hopefully avoid pancreatitis. And there you could use VASCEPA, certainly in label for that, or you could use any of the other omega-3s that's on their label as well if triglycerides are 500 or more, or fibric acid. So any of them could lower triglycerides 500 or more, not for cardiovascular benefit, but for hopefully lowering pancreatitis, although none of them have been ever shown to do that, if triglycerides are 500 or more. If triglycerides are under 500, then you're looking at, is it additional persistent cardiac risk? If they had heart disease and triglycerides are under 500, I would certainly give VASCEPA. That's on-label use of the drug. But if they haven't had heart disease and don't have diabetes, that's where it comes to your own clinical judgment. Personally, for me, in my experience, if I had someone with pre-diabetes and other cardiac risk factors and their triglycerides are high, I will give VASCEPA. That would technically be off-label for its cardiac benefit, but what's diabetes? If Dr. DeFranzo, who Curtis works with, it's a spectrum. Okay, if 6'5" is diabetes, if you're 6'4" A1C and you have pre-diabetes, that means, okay, you're not at cardiac risk, and as soon as you get that other 0.1, then you're at risk. So I'm a little more generous seeing the impressive data across the board with stroke and MI and death with this drug, that I extend what my own clinical judgment would be in someone who has high triglycerides, who's at risk for heart disease, that may not have had an event, but they may have pre-diabetes and not diabetes. So even though that was not the patient study had type 1 and type 2, was on a statin, on a statin with an LDL that was reasonable, and they either had heart disease in the past or didn't have heart disease, just have risk factors, or the cardiac patient. So the specific question, if the patient didn't have heart disease and didn't have diabetes, would I still give VASCEPA there? If they had pre-diabetes and risk factors, I'm not going to twiddle my thumbs and wait till they get diabetes. I probably would treat them.
Great, thank you. I think Curtis is still here, but Dr. Bush, I'll throw the next question to you. And it says, for patients concerned about cost, can you share your experience with respect to commercial managed care coverage of VASCEPA since the label change?
Yeah, so since the label change, before the label change, we had to get prior auths on people, even though it was in the literature. Remember, it came out at the heart meetings November 2018, and there was a lot of recommendations, and the ADA recommended it even before the FDA recommended it. The ADA recommended it based on the REDUCE-IT trial last year's ADA meeting in June. But in terms of cost, now patients who couldn't afford it before, or we could get the prior auth, now we hardly even need a prior auth, and the $9 voucher is for 3 months, $9 for 3 months to get 3 months supply of the med. So it's much more generous in terms of coverage now than it was before. I don't have to spar as much. So being committed to lowering persistent cardiac risk, I tried to get prior auths, and not all of them went through in the past. Now it's very easy. So we're very spoiled in our area for patients who either have diabetes and risk factors or who've had a cardiac event. Managed care is covering it, and it's $9 with the voucher. And even some of the Medicare providers are covering this very generously. After all, if they do the math and say, look, I'm going to lower a stroke or an MI, that saves them a lot of money in the long run and improves the patient's quality of life.
Wonderful, thank you. Dr. Bush, I'm going to ask you another question. It says, if a patient with statin-controlled LDL cholesterol and elevated triglycerides at risk for cardiovascular events and in need of additional therapy, I think it's asking if a patient has those, would they need additional therapy?
Well, I'm sorry, could you read can you say the first part again? If the patient?
Yeah. Is a patient with statin-controlled LDL cholesterol and elevated triglycerides at risk for CV events and in need of additional therapy?
Yeah, that's the patient in the study. They're on a statin. Their LDL is good. Some of the patients' LDLs in this study were down to 40. In fact, when I recruited, you could be 40 to 99. So if your LDL was 40 on a statin, but your triglycerides over 150, those patients still made it in the study and still had benefit. So patients well controlled on a statin, the triglyceride being above 150 is an indicator of additional persistent or residual, however you want to call it, cardiac risk. You didn't eliminate their risk, and giving the drug worked in those patients, even though their LDL was good. The LDL could be 41, and they'd still be in the study and still have benefit if their triglycerides were over 150 and they had heart disease or diabetes and risk factors.
Great, thank you so much for that. So we are going to wrap up soon, but before we do, I would love to get any final thoughts from each of you before we close out. So Dr. Bush, could you provide us with some final remarks?
Yeah, when you walk in the exam room with your patient with diabetes and you want to benefit their heart, where's your ACE or ARB? Is their blood pressure down? Where's the statin? Is their LDL below 70 or below 55 if they had heart disease, or even lower than that? Are they on a heart-smart diabetes drug like GLP or SGLT2 that has cardiac benefit? And importantly, if the triglycerides are over 150 and they have risk factors or have previous heart disease, where's the VASCEPA? That's the same obligation as all those other things. So we could do one better than before and lower that risk in addition. Otherwise, we could still be giving sulfonylurea and aldomet and cholestyramine if we want to practice like 30 years ago. So you could always do one better, and the data here is very impressive that the benefit far outweighs the minimal risk.
Great, thanks so much, Dr. Bush. And Curtis, any final remarks from you?
Yeah, just that as we're speaking to so many diabetes educators, I want to remind you that this trial had about 60% of people with diabetes in it, and that the results were very, very positive. So if you look at the people who didn't have cardiovascular disease but a couple of risk factors, over 5 years you had to treat 25 people to reduce an event. And if you had cardiovascular disease, it was 10. And I think that's something that I think it's our responsibility now to start going back and trying to look at some of our patients who are on agents that may not have cardiovascular benefit. We do this all the time. Practices change, evidence changes, and we have to move forward. And so as diabetes educators, I think it behooves us to look at this data, understand its importance, and understand that probably we need to start going through the patients that visit us and to reiterate that there's a better drug probably to help lower their cardiovascular risk. As I said, all the diabetes patients that come to me have at least a couple of risk factors. So if they maximize their statin and they still have a high risk, and that's true of most of them, you know, we need to consider whether this drug is appropriate. And that's something that, you know, the paradigms change all the time. As Dr. Bush said, you know, we went through the GLP-1s and cardiovascular disease. We went through SGLT2s, cardiovascular disease, and I think we need to throw this one into the mix now and really understand that it's important for us to start looking at it in our diabetes patients.
Wonderful. Thank you both so much. Thank you, Dr. Robert Bush and Dr. Curtis Triplett, for presenting today, sharing this tremendous data and your clinical perspectives. And we want to thank all of you for attending today's webinar. This webinar was recorded, and we will be posting it on our website, diabeteseducator.org. You can navigate to it by going to the Education dropdown, and under Webinars, click on Focus on Persistent Cardiovascular Risk. And we also have direct links to that page in both the web links box and the information box that you have on your screen. So thank you all. This concludes today's presentation.